Hi, I'm currently in the last 3 months of my PhD, and the ultimate aim of the PhD was to improve rare event detection. And this is one of my three foundational projects, and the most recent too. Now, bear in mind that much of these findings are very early on, and some of the work that's happening it still needs to be validated with external data, but we have clinically validated our model. Ooh, okay. So I want to tell you a little bit about what drove me to get into this area of research. So there's a high number of medical models that are performing very well in AI and ML. And with recent advent of COVID, it has driven a need for emergency ML. Many of these models tend to be focused on hypervalence data sets and often miss the small diseases which are harder to identify and in a machine learning scenarios and such AI scenario, more difficult and more easily overfit. So in the area I'm working in currently, there is only really four research papers applying AI to Fabry diagnosis, and they often tend to be very specific, looking at a specific marker and the application to that marker. So we've kind of come together and done a bit more of a broader study in cardiology. So I'll give you a little bit of a background on what the condition is, how similar it is to the other condition we're trying to differentiate it from, HCM. How our collection process for this is completely a novel data set that we have collected, me and another colleague in Cardiff University. So this is probably the first unique study done on it. And then how we have mined cardiac markers to find novel insights. And we're very happy to say that we've got something to show you that's just recently been showcased at World Symposium, and it's a marker that's promising in the area of Fabry. And then I'll talk to you a little bit about how we're trying to collaborate with clinicians to understand what questions they're asking us and how we can feed back to them better, and how we can improve our models too. Perfect. So Fabry is um, it's often it's a deposition of GL3. And in the early stages, it starts causing damage to the heart. And that's even before significant symptoms can occur. And we often pick it up quite late. So many times you'll see left ventricular hypertrophy start forming, and then there's a delay of a decade or so to diagnosis. And that's also driven by the fact that there's the biomarkers that are used currently in these studies lack specificity. Um, so that formation of LVH can present very similarly to hypertrophic cardiomyopathy, which is the two conditions that we're very interested in differentiating. Mainly also because hypertrophic cardiomyopathy has a prevalence of 1 in 500, whereas Fabry is very small and has a prevalence of 1 in 2,000 to 9,000. So I'm really going to leave you there because of the sake of time. And I want to really introduce you to our approach. So we collected, again, as I mentioned, a novel data set. A lot of the same barriers you face in the NHS, where this data is stored in a PDF file and you have to transcribe it and completely create a completely new tool. And the creation of this tool has served very well to other researchers within the cardiology department, looking at these reports, mainly being the ECG, echocardiography, and Holter reports, and it will serve them very well in the future. Um, and what we did was we took all that data for about 100 HCM patients and 49 Fabry patients, and we transcribed it and got all the values they've had throughout their diagnostic journey. And many of these periods, we've had to encapsulate them in what we term as an investigation period. So the clinician itself will look at an ECG report. He will often decide whether further investigation is necessary and in what form that further investigation is necessary. So we're talking about echography or Holter monitors, or both in many cases. And we found an optimal balance between the number of reports we could get, so the data quality, essentially enhancing that, um, and the number of investigation periods, so that we could maximize the balance between both conditions. And that was around 45 to 90 days after that first ECG effect. So we took an approach where we literally threw a lot of the most interpretable models at it, just to really understand what kind of patterns are there within the data set. So when we looked at this, we used both tree-based approaches, which look at more of a hierarchical decision process, but we also looked at clustering algorithms that focus on looking at patient similarities and grouping them close together. And then we also took those models and joined them together to use their advantages that they bring individually, um, to create ensemble methods. And what we've actually found is that these ensemble methods are performing a lot better than the individual models on their own. And this is because within these conditions, you're finding that patients that are very similar to other patients are often found close together, but there is also a hierarchical decision process being at play. So you've got this combination between similarity of the patient at a high dimensional space, but also this hierarchical decision process, which is more common to the clinician's decision process. So you can see both of them displayed on the top right. And we found that this extreme gradient boosting, as is a very common model amongst AI, is achieving the best and best results at differentiating these two conditions. So I'd like to talk to you about a bit of what it's actually found. Um, so it's located many of the markers that we thought were found across literature. So that being the QRS duration being larger within Fabry patients, age and gender being significantly differentiating factors. But what was quite interesting to us, which we continuously saw through multiple iterations with the model and with the data and scrambling it and throwing it back again just to see if really this was the pattern that we were observing, was that this t-axis, there was a certain threshold outside the normal range, which were actually showing to be more correlated with a certain condition. So as you can see on the display on the right, the t-axis is high values within the t-axis would normally be more correlated with HCM, so hypertrophic cardiomyopathy, whereas low values were correlated with Fabry. And as you can see on the figure on the left, there's a really big dip where it basically the prediction value for these conditions sets in, and you've got a normal range where the values don't shift too much and the impact on the model is not high. But outside these ranges, you find that high values impact the model slightly, the model's decision, so whether it's this condition or the other. But very low values have a very high impact. So we're very looking at that very sensitive range. And what we then did was we started talking to our cardiologist and our expert and wanted to understand whether any of these really nice looking plots for us, but maybe for them it didn't really make any sense. So we wanted to really look at whether we could design something that would aid them and allow them the space and time to understand the results from these models, while we could then seek more data on these patients and validate our model further in our insights. Um, and what we have an approach that we're currently working on where we use a language model combined with some form of understanding uh, of the risk that each of those words or phrases or markers in our case provide to the final outcome of the patient. And we create this chatbot where clinicians can um, interact with it and and we can see the questions that they're asking the chatbot and the insight they're seeking. So the benefit to having a system like this is the idea that you adopt and get the questions that they're asking, you present them the information at both a patient level and a generic trends of the disease, which is often two different interpretation methods in ML. And you bring them an awareness, a direct, very interactive awareness of what these conditions, how these conditions are behaving, and what factors are very important to that patient's diagnosis. So that plays into what we call a supporting a clinical support decision tool. And it would essentially a very, very early version of this, which is literally just work I've done in the last week, would present a sort of framework where you've got visit 1, 2, 3, 4, and 5, and you're gaining an understanding of how the patient's condition evolves. And yeah, I'll leave it there for the sake of time. And thank you very much for your time.